시청자 여러분 안녕하세요.
Greetings, ladies and gentlemen. This is Prosthodontics on Friday Live, which addresses different prosthodontic steps involved in implant treatment, as well as its side effects. This is the final Prosthodontics on Friday in 2022. We have a special guest, Professor Lee-Gyu Boka of Gyeongbuk University Dental School is here with us. He's going to talk under the title, Why Do I Worry First If There's No Screw Hole in the Implant Occlusal Table? Greetings. Greetings. I'm sure you're very busy teaching patients, doing research and treating patients. And despite your busy schedule, thank you for coming to Prosthodontics on Friday. I would like to express my gratitude for you providing a lecture on a topic that is of interest to many dentists. Could you summarize your lecture today? Today, I'm going to talk about how we use screw type, SCRP type, and cement type in doing implanted prosthesis. So the biggest reason why we provide screw type implant prosthesis for patient is to do repair when necessary. If we do this, there's a hole on the occlusal table. Aesthetically and functionally, it may be a bit unstable. The gist of my lecture is this. Think about a prosthesis where we can detach when necessary and can provide an ideal occlusal table using cemented type. So I would like to provide this information in an easy manner. It's a very interesting topic. I look forward to today's Prosthodontics on Friday. I look forward to your lecture. Those of you watching the program from the dental side, you can participate to real time via the chat screen. Leave your questions, have them answered, and try your chance at winning Starbucks coffee coupons. Among the questions, the best question will be selected and 3 Starbucks coffee coupons will be sent. Learn your prosthodontics and earn your coffee coupons. I look forward to your keen interest and let us begin Professor Lee-Gyu Boka's lecture. This is the topic of the day. It's quite unique. Let us change it a bit more fancy. Aesthetics, function, and convenience. Catching 3 rabbits with 1 stone. When we provide implanted prosthesis, let us look into whether we'll be able to catch those 3 rabbits. When I did some market research in Korea, SCRP or ER type is primarily used. Including screw type and SCRP type, it's 70%, and cement type takes about 30%. In OSTEM, SCRP type is referred to as easy retrievable type or ER type. This is overseas data, the US data. It's the other way around. Screw type is used less frequently. Cement type is used quite frequently. The reason why the percentage exceeds 100% is because a dentist does not use just one type. At times you use screw type and in other times you use cement type. Unlike Korea, the US dentists tended to use cement type more frequently. I first placed my first single implant to a person junior to me when I was a resident. At the time, I used a screw type and I wondered how I could get more aesthetic outcome. And since then, for 20 years, for 80% of the time, I used a cemented type. When I provide implanted prosthesis, I've wondered about these. It can be largely divided into 2. First, I wanted the patient to be unable to discern between implant and natural tooth. The second, I wanted it to be easy for me. If you look at the implant treatments, you'd have to reinforce it with pattern resin and take impression. At times, you'd have to do long bridge because it didn't fit well. It was really troublesome. How could I alleviate these troubles? More specifically, 8 questions came to mind. First is, I wanted the emergence profile to be more natural and occlusal table to resemble that of natural tooth. I wanted to use aesthetic material and I didn't want it to fracture. I wanted to make periodontal ligament. When overload is applied, perhaps there could be a sensor to avoid excessive masticatory force being applied there. I wanted to address areas where I could treat and chair side, and I wanted the fit to be good. I also wanted to retrieve if necessary whenever. Between implant and abutment, it is screwed with a screw, and there can be screw loosening and screw hole fracture. I wondered if there could be a structure without screw. I've wondered upon this for 25 years, and as shown, the 3 on top and 2 below were addressed. I did not address it, but the entire dental field worked together to address these issues. The remaining 3 we're still working on it. Let's look at the 5 issues that were addressed. First, natural emergence profile. If you look over here, this is the image of my patient in 2004. At the time, stock abutment was milled. In the lower second molar area, you can see that the abutment is not really aesthetic. It was milled and excessive sized crown was provided. The amount of gold was quite significant as well at times because there was no bone when implants are placed deep because there's limitation in terms of abutment height for stock abutment. So even if I use the longest one, the prosthesis turned out long. Porcelain, even though it's thick, does not mean it does not fracture. If you use angled abutment because the angle is deviated, you need to use a triangulated device and angle needed to be measured and depth needed to be measured. Those of you who are new in dentistry may not even know what these are. Once you choose the angled abutment following the gingival path, you would mill it. The abutment is not aesthetic. To provide aesthetic prosthesis is really difficult in this case. There are different abutments available from different manufacturers, and you'd have to study the different catalog pamphlets. It also took time for delivery. You'd have to make a cabinetry and you would have to stock these up. With CAD/CAM's advent, these concerns were resolved. We can provide customized abutment to patients like custom suits. As shown on the image, we can provide custom abutment with a very nice contour. In Austin, there is a pre-milled abutment available. It has a very good fit and the rod can be milled here and customized abutment can be fabricated. What is most important here is emergence profile angle. On the left image, gingival cuff, and on the right, transition zone. That's what we call these areas. What is shown in red is that area. The design here, no patient has the same design, just like everyone looks different. It's really a blessing for us to be able to provide a custom solution to our patients. A lot of discussion is around whether we need to make the profile concave, convex, or straight. Basically, you need to secure sufficient learning room. Concave is ideal. Convex is dangerous at times depending on the depths of the bone. You can make it straight, but the most important is to secure learning room to prevent inflammatory response or bone resorption. Theoretically, 2 millimeters from CEJ You need to place the implant similar to that diameter, but we no longer place 6 mm, 7 mm implant in the molar area. We place about the 4 mm implant. In that case, emergence angle increases. If the emergence angle is beyond 30 degrees, there is a higher risk of peri-implantitis, so this is not recommended. There are many different implant types available, including bone level, tissue level, external, and internal type. Tissue level implant is designed as shown in image 3. Periodontally, the prognosis is very good long term. In my case, I like to make customized abutment. From prosthodontics view, if you use a bone level implant, internal type, and if the running room is sufficient, I prefer this kind of design. Let me share with you a case that has failed. If you look at the x-ray, the implant is not placed deep enough. I wish it would have been placed deeper. It's been placed much shallower than the bone, and the implanted top is aligned with gingival line. In order to make embrasure aesthetic, food impaction occurred continuously and aesthetics decreased. This was the result that occurred. Inevitably, the emergence angle was almost 90 degrees. It's been about 4 years and 6 months, and as shown on the right panoramic image, the bone was resorbed significantly. You cannot say that this is 100% due to emergence angle, but I'm sure it has caused a negative impact. If you look at this patient, in the upper right, the emergence profile looks very natural. If you look at number 26, the implant is placed too far. In order to compensate for that, the design came up like this. Running room is lacking. I wish there were more space. If the implant placement position is wrong, prosthodontically, it is very difficult to solve it. How do you address this? Top-down approach. We discuss about this a lot. From the crown design, we need to do a good job utilizing CT data. If we do guided surgery, we'll be able to place the implant in the desired position, depth, and angle. Therefore, natural emergence profile can be gained. These days, guided surgery is utilized. Scan body is used to send the scan data to the lab. And that's all you have to do as a dentist. From 360 degrees, from top and bottom, you'll be able to provide a one and only abutment to the patient. These days, it is very easy to provide implanted prosthesis to our patients. First, we have addressed this issue. Let's look at the second issue. Can we make a natural occlusion? I think material is very important and needs to be aesthetic and not fractured. Let's take a look. This is a patient in 2005. A stock abutment was milled and abutment was provided. In order to provide aesthetic restoration, porcelain occlusion was provided. Metal ceramic crown was cemented. It's been about 7 years. If you look at the image on the left, number 7, the occlusion is okay, but number 6, it's all gone. What's wrong? If you look at the image on the right, because occlusion occurred only in number 6, I'm sure you have similar experiences. Implant porcelain occlusion. We know that the porcelain chipping or fracture is bound to occur. If you look at this patient in the most distal tooth, if you do bridge, I added gold to the restoration. I tried this once, but it looked so unaesthetic, I never tried it again. In order to make a gold occlusion, the amount of gold that is necessary is too excessive. You end up with this 10th amount abutment. With the advent of zirconia, such concerns have been largely addressed. Zirconia is from zirconium, which is atomic number 40. As it acidifies, it becomes zirconia and it becomes a white gold. It goes through transformational toughening. Therefore, it can resist fracture and we can rely on it. It can be used not just on implant but on premolar in the lower right quadrant. You can use it regardless of whether it is natural tooth or implant. You can provide a full zirconia restoration. This was not available from the beginning in 2010. I provided zirconia ceramic crown. So I added a ceramic veneer on top of zirconia frame. On the distal buccal area, fracture occurred. There's chipping. I did it once again, and similar fracture occurred once again. Therefore, I changed the restoration to full zirconia. In 2012, at the time, the block was rather opaque, and it was unesthetic. Because of such opacity, ceramic veneer was added, but actually zirconia is strong and ceramic is weak. Rather, all ceramic crowns are stronger. In the case of interior area, all ceramic bridges are provided. Lithium disilicate 3-unit bridges are provided from number 11 to 13. If you take a closer look, a connector area is fractured. If you look at the overseas literature, interior 3-unit bridge is reported to be stable. However, considering the tough eating habits of Koreans, it fractured. Zirconia framework was provided, ceramic veneering was done, and restoration was provided once again. I gained confidence and attempted the anterior 6-unit long bridge. Using 3 abutments, a 6-unit bridge was provided after final restoration. Not long after, chipping continued to occur. If you provide long bridge, stress is applied more stronger and chipping occurs more frequently. Resin buildup was done like this. Full zirconia restoration. Zirconia long bridge was used to replace the restoration. It is slightly opaque, but staining was done. The patient was older, male patient, so the patient was satisfied. From dentist perspective, it's not really satisfactory. If you look at the implant in number 2014, it's slightly opaque. Occlusion, it's very good. The fit was very good. However, there's a bit of opacity. If you look at the right image with time, with added yttria, transparency has been improved. Number 46, gold crown, was replaced with full zirconia crown. If you look at the left image, the implant and the first molar on the right, there is a lot of wear, and zirconia crown was provided. In the anterior image, I set this restoration 2 days ago. This is anterior 4-unit bridge. It is full zirconia bridge, but it's very aesthetic these days. Gradation block is available, and a very natural looking restoration is possible, very similar to that of ceramic crown. Professor, if you look at the slide, gradation block, 3-layer zirconia block. It's mentioned like this. You've provided a very aesthetic restoration. Do you use it very frequently? If so, can you provide us how it was clinically? Could you provide us your opinion in the case of anterior or posterior area? Can we use this material for bridge? In the case of multi-layer block or gradation block, it's been available quite some time. Yttria has been added, aesthetics and transparency has been improved. In the early days, aesthetics was improved, but the strength was about 600 megapascal, so it decreased significantly. In the case of anterior area, you cannot really use it if the number of units exceed 3. In the case of posterior area, it fractured quite frequently. In the case of multi-layer block these days, such properties have been improved significantly, and domestic products have over 1000 megapascal. The colors are better, and aesthetically, it's better. You no longer have to do the staining as you did in the old days. The color is very pretty. Some people ask me how many unit bridges I can do. If the material is over 1000 megapascal, I use it for 6 unit bridges in the anterior zone without worrying. You can use it for 4 unit, 5 unit bridges as well. In the case of posterior natural tooth, the amount of prep is very important. If you prep wrong and if the thickness is weak, even if you use 800 megapascal material, it can fracture, therefore you need to be cautious. You need to check with the lab what kind of multi-layer block they're using. Based on ISO standard, it needs to be over class 5. If you use such block, then you can just rely on it. Thank you. There are many questions on the real-time chat screen. Let's entertain a couple. Ramen Men. I look forward to today's prosthodontics on Friday. Wise Dental Life. Professor Joyno, Professor Lee Gyubok. I look forward to today's prosthodontics on Friday live. Let's look at some actual questions. Let's scroll down. I love dental. SCRP prosthesis is fabricated. Abutment is fit in. I check the fit with prosthesis, adjusted, and I remove the abutment and place the healing abutment, and extraorally, I permanently set it, and then I remove the healing. This is my protocol. What is your protocol like? I think your SCRP protocol looks good. The benefit of SCRP is that you can do setting and cementation, and then you remove it and remove excess cement. In the question, cementation is done extraorally here. In general, you cement it intraorally and then remove it and remove excess cement. Yes, that is the general way, because if you do cementation extraorally, the position can change. I think you need to do it intraorally. I agree. The protocol, rather than doing cementation extraorally, you need to do it intraorally and then remove it and remove excess cement. That is the recommendation. You have provided the perfect answer. I have another question. When I place custom abutment, at times patient complain of pain. What should I do? Yes, I've received such questions. At times, patient says it hurts. Yes, I have such experience. Some dentists try to make aesthetic restoration by widening the emergence profile and removing embrasure space and undercut and make it really big. From the initial get-go, they compress it, and when the patient complains of pain, they provide local anesthesia. In my opinion, if you compress it too early, gingival recession can occur. Yes. There can be gingival inflammation because of compression. I agree. If you fabricate customized abutment that is really in line with patient's gingiva, basically there's not that much pain. Emergence profile, if it is concave and nicely made, even if there's pain, it's transient. Even if the patient complains of pain, it's only temporary. Even if you tighten completely, the pain disappears within 1 or 2 minutes, 5 at the most. At times, it is bleached. Excessive bleaching should be prevented, and this is gone within 5 minutes. This is the way to go. There's topical agent as well. For patients complaining of pain, you can use topical anesthesia on the socket, and it can help. Yes. It's not as dramatic as the injection anesthesia, but it can help. In the textbooks, it says that emergence profile should not exceed 30 degrees. If excessive compression is applied and if the patient continues to complain of pain, we need to consider this factor. I have a working communication system with my lab technician, so I can do setting without any issues. So my restorations come out looking naturally. You need to adjust with your lab technician. Yoon 2418, it's very difficult to choose implant material. Gongduri, will it help in choosing big healing abutments from healing phase? If you choose a thicker healing abutment, will it help? If you use a wide diameter healing abutment, will it help? Because of this, in the past, Anatomic healing abutment were available in the market. The size were almost similar to the CEJ diameter of natural tooth. I tried it once. With healing, significant gingival resorption occurs. We normally use 4mm, 5mm healing abutment after primary surgery, even if the results would have been fine. If you use a significant size healing abutment, gingival resorption occurs significantly. If you use large size healing abutment to minimize pain and to make the look natural after surgery and after gingival stabilization, you need to gradually increase the size. Or else, if you compress it all of a sudden, the results may not come out ideally. Hadgui 1-2. Some dentists, in fear of the resin filling up the occlusal hole on the posterior implant from falling off, they just make this hole size really small, like that of a pinpoint, just to be aware of the screw position. Compare with normal screw hole size, which is more clinically advantageous. I assume the normal size hole would be better. If you make it pinpointed, it is difficult to view as screw type. It is cement type. This will be addressed in my lecture later, but because it is difficult to find the position, you form pinpoint. It can help. Other dentists don't use a pinpoint. They just use a staining in that area, perhaps in yellow, so that it is easy to find it. Yes. ID hula ola. At times, zirconia crowns fracture. How can I reduce such frequency? It may be related to implant, but in general, how do you do it? In the case of implant crown, when we design abutment, you can get sufficient thickness. So therefore, it rarely fractures. However, in the case of natural tooth, there is limitation in terms of prep. Therefore, there are cases where it fractures. First, you need to do prep appropriately. Zirconia thickness needs to be over 1mm. If the amount of prep is insufficient, when you mill zirconia using CAD/CAM, because of milling tool and other factors, there's a lot of space in occlusal table. If you prep the occlusal surface 1mm, the thickness of zirconia's occlusal surface is less than 0.8mm. I recommend reduction of 1.5mm in occlusal surface. You need to pay attention to axial wall as well, or else there can be other issues as well. You need to look at the properties of material depending on which block you use. It's difficult to pinpoint which country, but if you use cheap product, it may be not so good. In the case of natural tooth, you need to consider the thickness of margin. Once we do the scan and transfer the data, at times there's a still internal gap. At times, it is squished when you do rubber impression and there can be error. The fit should be passive fit. This is not metal. It does not have ductility and malleability. It is ceramic. If it does not have passive fit and if pressure is applied, fracture can occur, especially in the marginal area. Crown with a passive fit and consistent internal gap is very important. You need to do prep properly. And you need to make the crown properly. TS, when patients come in with existing implant, how much of alveolar bone loss would you recommend retreatment? At times, patients come in with implants placed from a different dental clinic due to changes in address and such. I think it is slightly off topic. This will be addressed in the next opportunity. I have a question. How thick should the margin be if I provide a zirconia crown to natural tooth? When we provide crown for implant, it can be sufficiently thick when we provide crown for natural tooth because there's limitation in prep. Chamfer should be good, but shallow chamfer is frequently done as well. Because natural tooth is vital, you cannot just prep it. In the case of lower posterior lingual area, it is lingually tilted. In my case, a lot of cases, it becomes knife edge. If you look at the literature from old, there's a lot of literature on strength of zirconia. Knife edge, it says, is okay. At times, in the case of lower lingual side, if the prep amount is limited, it becomes knife edge. So impression is taken well, and if there's passive fit, it's okay. Or else, when you check occlusion, you might find it fractured. Many factors are important, but I think at the very least, there needs to be shallow chamfer. There are many more questions, but we will entertain your lecture first, and then we will address the rest of the questions. Thank you for the answers. Dear viewers, thank you for raising questions and leaving words of encouragement, and I look forward to your keen interest. Please raise many questions, and with lucky draw, we'll send coffee coupons. Professor, please carry on with your lecture. This is the image of the patient which I've just shown you. The results are very aesthetic. The blocks are great these days, and I really appreciate it. Natural looking occlusion and aesthetics. Fourth is fitness without adjustment, reducing the need for chairside work. Let me show you this video clip to answer this. This is an implant patient. The scan body was used for scan, and scan data was sent to the lab. And in the lab, custom abutment, zirconia crown were fabricated in one stage. And before delivering it on the 3D printed model, it has been tried in. Let me show you how it is set within patient's oral cavity. I'm sure you can hear the sound of the video clip, but ideally there should be resin jig, but even without jig, you can position it. This is RCS design, it's internal type. There's lingual stop, so you can position it very easily. You can hold it like this and tighten it. After that, you can put the crown in. This has not been edited. This is raw video clip. The margin is very good. You can check it visually. You need to check the contact. I'm not sure whether you can hear it, but you can get the sound when there's very ideal contact. Occlusal check needs to be done. Occlusion. In adjacent teeth, the shim stock comes off with very little resistance. Did you catch that when I was removing it? There's that unique sound. It's passive, and if the internal gap is under 40 micrometer, there's that unique sound coming when it is removed. Occlusal adjustment is done. In intercuspal position, you make the same occlusion as adjacent teeth. Next, retrograde is done. Grip function is done in adjacent teeth, and in implant, interference is removed. I'm asking whether it fits nicely to the patient. Temporary implanted cement is used. This is for implant. There is a slot in the lingual side, so if you push towards that, it comes out. After polymerization, the rest is removed. In the case of single implant, without further adjustment, it can be set very naturally. Some people may have doubts. Because we need to be able to provide evidence, we have done many research. This is a study published in 2020. This is a clinical study. Rubber impression was taken in patient oral cavity. Model was fabricated. Model scan was done. With this, 3 other oral scanners were compared. Lithium disilicate crown was fabricated, and I compared it in patient oral cavity. In the case of oral scanner I500 and CS3600, I'm sure you're aware of it. In the case of Easy Spio, this is the previous model of ray scan. 3-shape Eon scanner was used for model scan. This is the result. The left is marginal fit and right is internal fit. In yellow is the conventional way rubber impression and model scan. The rest is oral scan. Oral scan shows better result. It's the same for internal fit. The oral scanner showed better result and results are similar. In natural tooth, using oral scan shows good fit. Let's look at implant. For A and B, scan bodies were used. And C and D, rubber impression was done. C was plastic cap and D was pickup impression.
레진 모델상에서 실제 환자에게 임플란트 식립하듯이 픽셀 식립하고 4가지 방법으로 임프레션을 체득하고 다시 이 임플란트 크라운을 제작한 다음에 모델상에 시적을 하고 스캔을 The 2 models were scanned and superimposition was done. Proximal contact, distal contact, occlusal contact were analyzed for accuracy and precision. Let's look at the results. The upper left is mesial contact, the next one is the distal contact, and the one below is occlusal contact. On the graph, the 2 scan body were used. Regardless of whether it was a proximal or occlusal contact, the ones using scan bodies show higher accuracy. That's why in the case of single implant crown, at times if you scan and send over the data, there's no need for adjustment. It's quite surprising. And there are precautions. As shown in the graph in the middle, this graph actually shows everything. This is 1 type of model scan and 4 types of oral scanners. They were compared. The graph in the middle, if you look at the green line, it is model scanner. Model scanner scans the entire model from left second molar to right second molar. If you compare the entire arch, there is no major difference, but in the case of oral scanner, it may vary depending on the scanner, but you can see that error is superimposition. If you look at the right side on top, it is a distortion in red. Oral scanners have small scan field, therefore error is superimposition. The certain oral scanners we can rely up to 5-unit bridge. The amount of error is very low. Other scanners can handle up to 3-unit bridge and others may be only fit for single crowns. We need to be aware of the performance of the scanner that we use. I have conducted additional research. This research was published in 2020. 2 model scans and 5 oral scans were compared. If you look at the level of deviation compared with model scan, oral scanners show higher deviations, but some oral scanners show high accuracy. If you look at the right graph, anterior area, there is less distortion. In the posterior area, there is more distortion. If you look at the color map A, B, the 2 are model scans and the one below are oral scans. There are significant distortions and the direction of distortion differ by oral scanners. The recommended scanning method is different by different manufacturers. The left shows when it has been scanned all at once and the right side shows when it has been divided by 2 times. It seems when it was divided by 2 times, it shows a superior performance, but if you take a closer look, depending on the scanning method, some scanners do not show difference, but certain scanners show significant difference depending on the scanning method. Therefore, you need to be aware of the performance of the oral scanner that you use and the properties it has. If you're aware of it, you'll be able to get better results. In terms of fit, there are still limitations, but Compared with the traditional method, there's potential for the oral scanner to provide a better restoration with better fit. If we continue to develop on it, we'll be able to make it more convenient. This is the last, easy retrievability. It's a very important topic. If you look at YouTube, you can see the dentist trying to remove the SCRP type crown. What would it feel like from patient perspective? They may worry whether the implant will fall off or not. In my case, as mentioned earlier, I used to do a lot of cement type. It was really difficult to retrieve it. At times, this kind of situation occurs because I could not find a hole. The occlusal surface was removed entirely. I was concerned about damaging the abutment so much so that I ended up cutting this into half. I almost used the entire handpiece cartridge and it was really difficult for me. As Professor Cho has mentioned in the past, we always wondered how to find the screw hole when we provided cement type restorations. If you look at the literature on X-ray, we can find it, but it's very difficult to make the hole as shown on the right. Therefore, some people mark it on the abutment or take images, or they would draw on the chart in order to find the hole when necessary. As was mentioned, you can mark it like a tattoo. You make a little dot using the stains. But as the patient uses the crown, the glazing can be removed or disappear. Porcelain chipping can occur as well. Then it'll be very difficult to find the position. In order to be able to locate the hole more precisely, some people make these locating devices which you can store and use when necessary, or you can also make it in an omniback way. But it's very difficult to keep it 5-10 years and there's danger of deformation. This is the best way personally. If you make it using CAD/CAM, even if the hole position is weird, you can call the lab and ask the lab to send over the patient data. You can just look at the image and find the hole in a very easy manner. Personally, I like this the best. The 5 different ways that I've mentioned, in the end, you need to punch a hole through the occlusal table. Then it's no different from SCRP or screw type. In the end, we end up with this hole. Can we forego this hole? Let's look at this video. This is RCS type with a lingual slot. Wait 1 second. I'm going to click on it. On the lingual side, there is a slot. Resin cement was used. High speed was used. You can use number 330 burr or small round burr to remove the cement carefully. Once this is removed, there is a flathead driver. You can use it to apply torque. If you have automatic torque driver, you can apply 35 Newton centimeter and it'll come off. Because it was done with resin cement, it requires a bit of force. I'm sure you heard that sound. You can do screw tightening again after you've solved the issue and cement it. You can retrieve it very easily. This is not something that I've devised for the first time. When I looked at different literature, so there were 2 clinical studies. If you take a closer look, as mentioned, slots were formed and flathead driver is used. Then you can retrieve it. That is the basic principle. The design and my design is slightly different. The design has been improved. If you look here, compared with crown margin, the slot stop is more towards the occlusal surface because in the case of lower molar, if it is positioned towards the gingival line, then it'll be difficult to approach it. Therefore, it needs to be like this. In the early days,
when you mill crown with zirconia, you had to form slot because there was no slot, but now you can mill designs with slots. Look at lower left, you can see that there are different slots and the 3-unit bridge. Even if it is bridge and resin cement, it can be retrieved very easily. Torque driver is used. This is flat head to remove it. From August 2012, for about 2 years and 8 months, resin cement was used to provide RCS prosthesis. A total of 194 restorations were provided. The results were very good. It was very easy to retrieve, and I published it in many places. Many people, when they looked at it, were concerned about the resin cement not falling off properly. I had the exact experience. If the custom abutment's height is high and the volume is significant like this, and if the internal gap is consistent, if you use resin cement, it does not fall off easily. I had to apply 50 Newton centimeters using implant motor to retrieve it. In order to retrieve it easily, it should be retrieved with less than 35 Newton centimeters. So you need to consider the convergence angle and custom abutment height. These are being tested, but these are now no longer necessary because I set using temporary cement. Premier is also available from Austin. In the early days, I had concern about the zirconia strength, and I thought I needed to reinforce it with zirconia cement and the inner surface as well. I was concerned about retention. However, in the case of well-made custom abutment and zirconia crown, you just need a temporary cement to be able to retain it. At times it does fall off. In those cases, you can use resin cement. These days, on custom abutment, I use the dedicated temporary cement and provide treatment in a very easy manner. I'm almost done. Let's look and compare the 4 different videos. The one on the left is screw type. The 3 on the right is RCS, lingual slot type. Second one is resin cement. The 2 on the right is temporary cement called a semi-implant. The one on the middle, I used the flathead driver. The one on the far right, some people say I don't have torque driver, and where do I find the flathead driver? Actually, the one on the far right, you do not need this. A reverse mallet, we all have it. You can use it with reverse mallet. Let's compare it. It can be a bit loud. On the left side, resin is being removed. Cotton and Teflon is removed. As for the rest, on the slot area, using high speed, resin or temporary cement is removed. In the case of temporary cement, you can just use low speed. Let's look from the far right. You can see that it is retrieved very easily using reverse mallet. Torque is applied. The second on the right, temporary cement was used. So if you apply torque, it comes off. Let's look at the second one. The second one is resin cement. Therefore, you need to apply a bit of force. As for screw type, you can see that it has not been retrieved, and it's very difficult to reposition it later. As for screw type, it's very difficult to set and find the contact. Which method will you choose? I think we have addressed many obstacles for easy retrievability. Let me address the 3 factors that have not been addressed as of yet. We're working on it. Various patents have been raised since 2007 involving sheet memory alloy, hyperelasticity, rim and ball are used. As you can see, there's no screw. There's no screw between abutment and implant. Connection method using the different elasticity and unique feature of the implant. And as mentioned, I tried to reproduce the elasticity of PDL. To do this, I used coil spring and rim spring. So I came up with prototype using patents, but I failed in commercializing it. But there are very similar designs that have become commercialized. You can see spring and ball On the right is the different connection method. Unfortunately, the abutment and implant are connected using screw, and superstructure only used this method. I hope the screw part can be addressed as well. I've talked about the 5 concerns that I've had, and the 3 are still underway for resolution. As we work together, I'm sure we'll be able to come up with a treatment that will satisfy patients and dentists alike. Thank you for your attention. Dr. Kim, thank you for your interesting lecture. Let's look at the questions raised on the real-time chat screen. We've entertained up to ID Uaha, then all. I tend to use a thick healing abutment after placing implant deep in the posterior area. A lot of people prefer 4-pi. What are the pros and cons of thick and narrow healing abutment? This was addressed briefly before. I agree that placing implants deeper is good because you can utilize sufficient running room. But as for healing abutment, if you use excessively thick one, gingival inflammation and bone resorption can occur. Therefore, a lot of people prefer keeping it under 5-pi. If you want to widen it naturally for customized restoration, you need to proceed gradually after healing. Before providing final prosthesis, you need to gradually increase it. Understood? Dental student, if there's a lot of bone resorption in the posterior palatal area, what about placing the implant buccally and slightly tilting it towards the palatal side? And if the hole is towards the occlusal surface, appropriate occlusal force may not be applied. This is related to surgical area as well, but as mentioned, as a prosthodontist, I think doing prosthesis top-down way is very important. If you design the prosthesis well and make the screw hole design nicely, I think a position is most important. You can reinforce a bone amount. Implant, the antagonist of the implant site. If there's no antagonist, why do we need to provide implant? At times, people skip providing implant, others don't. Why do you provide implant if there's no antagonist? In the case of number 6 and 7, maybe there's only up to number 6 in the lower. Is there a need to place 2 implants in the upper? In that case, rather than placing 1, it is better to place 2 implants to reinforce it. If it is a single missing case and if there is no antagonist, I don't think there is the need to place implant. If you're going to place 1 implant in the upper and 1 implant in the lower, then it's going to be okay. TS, when you provide a customized abutment for the molar, at times it becomes wider than the healing abutment. What do you think about providing custom healing abutment or using Louis button? You can use healing abutment as scam body and as abutment for final prosthesis. There are many very good products available. For using it for emergence profile to customizing, because it is close to stuck abutment, there are limitations. I'm not really sure about Louis button. I will research into it and then provide response. It's my first time hearing it too. Dental student, maybe it's better to do bone graft and do top-down approach. I have my doubts because bone augmentation success rate is not 100%. I understand now. Bone graft is not 100% successful because of time constraint. I wish we could provide a more sufficient answer, but we apologize. If you provide implant treatment for the upper and lower molar on one side, if the occlusion is not right, what kind of procedure should I provide? I'm unsure about the question. If you can add to your question, we'll be able to provide your answer. After placing implant, maybe because of different positions, occlusion may not be right, perhaps? Yong Yong. In the case of cemented type prosthesis placed in a different dental clinic, how can I find the hole while minimizing the damage on prosthesis? You can use the 5 methods that I've mentioned earlier. As mentioned, if you use RCS type, things will become much more easier. If you have digital data file, you can ask the dental clinic to send it over. That's the best way. KY ortho. For patients with vertical dimension loss due to missing upper and lower molar, after implant prosthesis setting, at times patients complain of cheek biting. Based on my understanding, this is because the prosthesis is beyond the neutral zone. In this case, how can I position the implant in the neutral zone? This is a very difficult question. In my opinion, on top of my mind, if there are questions like this is because the teeth are missing on the posterior area. Therefore, we may use temporary bridge and continue on with adjustment at certain point. Then the patient will not complain of cheek biting, and we can provide final prosthesis in line with that design. That's a very good idea. If there's cheek biting in the posterior area, at times this is due to lack of overjet. Cusp design and angle are very important. By providing temporary prosthesis, and if the patient adjusts to it, we can find the right design. Then we can assume that the implant prosthesis is within neutral zone. In the end, the patient's cheek biting needs to be solved. If there is TMJ symptoms after implant prosthesis delivery, how can I respond to occlusal changes? In this case, you need to treat the TMJ symptoms first. Or you can use temporary prosthesis in this case. You can use provisional restoration here, long term, and wait for TMJ symptoms to improve, and then provide final prosthesis. I like dental. When I deliver cemented type, at times there is excessive cement in the gingival sulcus. How can I prevent this? In the past, when we used stock abutment, the position, diameter, because of these factors, the crown had to press down upon gingiva. When you do cementation, you cannot see it. It is very difficult to remove excess cement. Unless you use SCRP type, you will not be aware of excess cement. You'll be able to detect it on the X-ray. Because of these issues, you may need to make customized abutment and design gingival line to minimize this issue. And you can adjust the amount of cement you put in as well. Yes, and you need to make a path where excess cement can come out. If there is a lingual slot, the excess cement may come out from there. If you're aware of that lingual slot, you can utilize it. Professor, when you determine implant placement position, do you prefer having over 1.5 millimeter of surrounding bone around the implant or forming occlusal contact around the center of the implant? What kind of considerations do you have on these issues? If you use top-down method, it'll be good. Using digital dentistry, this will not be very difficult to do. I don't do surgery a lot. I'm sure there are more experts who will be able to answer this question. TS, this is a separate question. What kind of camera or imaging devices do you use? You have a very standardized system, and I envy that too. I'm a bit embarrassed. In the beginning, I used to spend more time taking images than treating patients. I used to use DSLR cameras. These days, I ask my residents to do it because I'm so busy. I would like to thank my residents once again borrowing this opportunity. I think this is one advantage you have when you're in a university hospital. Ammonite, upon porcelain chipping, what do you think about doing double crown, like prepping the chipped area and cementing once again? In this case, a screw hole will be removed, therefore it will be difficult to repair when necessary. I think this person means to say that we need to prep the chipped crown and then do crown again.
Yes, there are these methods available. I've never tried it. When there's a problem, it's the best to make a crown again. I do have this experience in the pontic area. When it is chipped, I have used this method. These days, if we use a zirconia, there's no chipping, so these issues are solved. Cool all. Fracture of implant veneering porcelain. This can be a result of changes to other dentition or occlusion. In the case of full zirconia restoration, if you cannot do occlusal adjustment, occlusal concentration can occur on the implant. What's your opinion on that? How do you do intraoral zirconia occlusal adjustment? In my case, upon setting, I form correct occlusion and I do not do occlusal adjustment during follow-up period. So this is something not I'm an expert in. How do I do occlusal adjustment for zirconia restoration? When I do it intraorally, the amount is not significant. The best is to do high-speed irrigation and use super diamond burr and make it smooth. Zirconia polishing kit these days are very good. You can use it to do polishing. If you do not do high polishing, as we all know, antagonist wear can be severe. There are 3-step polishing tools. Do well. Is there any polishing tip after occlusal adjustment intraorally? You have already mentioned this. Polishing is important. This may differ depending on manufacturer. Good idea. What do you use for prosthodontic cement? Do you use it differently depending on implanted type? How do you do cement removal? So this was mentioned briefly before. Talking about implant only, I use a temporary implant cement most frequently. In the case of Awesome, it's Premier. At times, custom height is really low, and if you're concerned about retention, in those cases, you can use resin cement. At times, if you use temporary cement, it does not last 1 or 2 years. In that case, you need to ask your patient whether he or she minds coming back every other year. If the patient does not want to come too frequently, we can change to resin cement. We also need to ask what patient's dietary habits are. Yes, that's important too. In the case of temporary cement, it's urethane base, so it has elasticity and it can be removed easily. In the case of resin cement, in the case of excess cement, it may not fill up the slot. Aesthetically, you need to remove and fill the slot area properly, and then you need to do curing. You do spot curing. Polymerization should not be done too long. If you do this, then it can be removed nice and clean. In the case of anterior area, due to path, at times a hole cannot be formed on the lingual side. In this case, shall we have to resort to cement type? In the past, in the case of anterior case, you had to use cement type, and if there were issues such as screw loosening, it was very difficult to find the hole. But as I've shown you in the 4 videos, even in the anterior area, slots can be formed. Red Cherry 1, in the case of long span implanted prosthesis, is there a protocol that you have to do occlusal adjustment well? At times, the occlusion may be an issue and it may be difficult to find the right bite. The question is about long span bridges. To do occlusal adjustment intraorally with the less than ideally made prosthesis can be really difficult. The tip for this is to stick to the basics. We need to adjust in ICP state, and when doing retro guide, appropriate guide should be formed. There's no special tip or protocol. You need to do polishing well. Ammonite. If the placement direction of bridge implant is different per ER type protocol, you need to set within patient's oral cavity and remove the prosthesis to remove the excess cement. When it is positioned once again, I believe that there can be cement gap. How do you do setting if the implant placement direction differ?
For instance, you apply a torque by 20 Newton centimeters each and then apply 30 Newton centimeters. ER type. I use custom abutment and cement type, so I don't have a lot of experience. But I believe, as mentioned, there could be cement gap due to tight contact. If you use custom abutment, even if the implant placement direction vary, it's not going to be a problem because it's the same as crown setting. The cementation way is the same. In this case, if you tighten screw separately, as mentioned, you need to apply small amount of torque each and then do final tightening. I think that'll be a great tip. Thank you. Tori, after first surgery, I placed the healing abutments, but the gingival healing did not occur and there is still the incision line. Will this be resolved with time? What should you do if the incision line does not heal for a long period of time? This is related to surgery, so this question will be addressed later. Uja, when you do pickup impression, is there a tip to make a good emergence profile? For instance, should I have the patient bite on the cotton for a couple of minutes and then do pickup impression? Or should I use abutment 1 millimeter smaller than that of the implant? In the past, we would provide temporary provisional first to prevent recession and would do gradual gingival remodeling. We would add resin and give it a couple of weeks' time. These days, if you use a 4 millimeter, 5 millimeter healing abutment, if you do implant level impression, the lab technician can make a very nice emergence profile. You don't need to worry about it. There's limited time, but there's a lot of questions left. Professor Lee Gyubok, you are very popular and there are so many questions. Because of time constraint, we will entertain questions from the bottom. Good evening. Is there another question? Good evening. If there is underbite in zirconia prosthesis, in order to add occlusal contact when adding ceramic on occlusal surface, is there any tip to add a ceramic? I think a lab technician should be able to answer this. First, there should not be underbite. Shin 8234. In the lingual slot area, won't the cement be washed out? It's a very important question. I also have a lingual slot implant in me. Even if you use resin cement with time, it deforms due to moisture. So it can be scratchy and you have to polish it. At times the slot, if it is rectangular, it can fall off. Therefore, you need to design the inner part wider, then it won't fall off easily. Currently, the slot in my implant is off. At first, it feels awkward, but with time, you get used to it. In the case of temporary cement, there's elasticity, but with deformation, it falls off. I follow up my patients every single year. Some patients come back with the slots fallen off, and when I ask the patient whether they were okay with it, in most cases, people don't even know it's gone, but those who feel discomfort, I add flowable resin to make it smooth again. Next, 12 MSF. Even if I do TS with temporary cement, at times it's difficult to remove it. But when I need to remove it, what can I do? If you use Professor Lee's system, you'll be able to forego this issue. In general, if the internal gap is very consistent, then temporary cement will not fall off easily. It could be difficult to remove cementation type. You need to cut it off. Other than that, nothing really comes to mind. Odal 2000. I am currently using ClickFit system. The benefit in it is that the spring serves as PDL and improves foot impaction. What's your opinion on it? I've shown ClickFit in the image, but I've never used it.
If it could serve this role, then it'll be great. I would have to get back to you on that after I use it. Ask away as I apply torque on the slot. Will the crown be fractured? Do you have experience of such fracture? As shown, if you apply 56 degrees and apply strong force, if you remove resin cement with high speed, there can be indentation. Also, there can be fracture if you apply too strong of a force. If you think of the slot as shown, it's quite thick. It rarely fractures fully. It can be scratched. If you polish it, then it's going to be okay. TS is the same question. Four-leaf clover. The slot type, can it be fabricated by all labs, or does only specific labs provide such prosthesis? I hope this could be solved. That when I provide these kind of lectures, people ask me where can I get them. These days, with labs that utilize CAD/CAM very well, they can utilize this design. But not a lot of people know lingual slot type. They do not know what the design is, so they cannot provide it. If you do not have lab that are aware of this design, I can send the design over. If you reach out personally, I can send over the contact information of the lab that can fabricate it. On the dental site, we can post the information along with the video. We can add such information. I hope you can utilize the dental site. There are so many more questions, but as for the rest of the questions, we will answer them separately. Professor Lee Gu-bok will answer them separately. I will answer them all. I'm sure a lot of people would want a response from Professor Lee. I hope for your participation, Professor. Thank you for providing wonderful answer to so many questions. I would like to express my gratitude to those who have participated in the chat. Professor Lee Gu-bok, we were not able to go through all the questions, but please pick the best question. I would love for your input. As for the best question, the person will receive 3 Starbucks coupons. One of the questions really was sharp. The person asked whether cement washout occurred in the slot area, and that was a really good question. I'm unsure who it was. Can we scroll down? 2 people actually asked the same question. Shin 8234. The cement washout on lingual slot. Another person also asked a similar question. Unfortunately, I'm unable to find that ID. Shin 8234. Congratulations. Coffee coupons will be sent on Monday to the winners. Don't feel too let down for not being selected as the best question. The Prosthodontics on Friday live chat event continues on next year, so I look forward to your keen participation. Professor, could you give a word of advice to the dentists who are studying hard watching prosthodontics on Friday until late? Thank you for watching up until such a late hour, and thank you for all the questions. As mentioned, the implant system has progressed significantly, and this is largely due to many researchers and manufacturers that have spearheaded such research. We need to carry on with this effort so that we be able to provide a very satisfactory result to all the patients. Thank you for your wonderful advice, and thank you for coming here despite your busy schedule. Dear viewers of Prosthodontics on Friday, how did you like the final Prosthodontics on Friday of 2022 with Professor Lee Gyu-bok? Professor Lee has mentioned about catching 3 rabbits with 1 stone, aesthetics, function, and convenience. I hope you were able to get useful tips on implant prosthesis. The answers to the questions that were not answered today will be addressed by Professor Lee Gyu-bok. Next year, we're going to have a lecture under the title Back to the Basic, involving full denture. We're going to look at the principles of fixed and removable prosthesis. Thank you for being with Prosthodontics on Friday nights this year. I look forward to meeting you again in 2023 with better and meaningful contents. Thank you, everyone.